Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Hello, I'm Jennifer Wyack, Professor of Medicine in the Division of Hematology at The Ohio State University Comprehensive Cancer Center in Columbus, Ohio in the United States. Welcome to this program titled Collaborative Care, Navigating Multidisciplinary Management of CLL and MCL for Optimal Patient Outcomes. Joining me today are Dr. Peter Draeger, Professor in the Department of Hematology at the University of Heidelberg in Heidelberg, Germany, Dr. Sanam Logavi, Associate Professor in the Department of Hematopathology at the University of Texas MD Anderson Cancer Center in Houston, Texas in the United States, and Josie Montegard, Nurse Practitioner at the Dana-Farber Cancer Institute in Boston, Massachusetts in the United States. Welcome, everybody. In this activity, we're going to first talk about who is involved in multidisciplinary meetings for patients and their roles. We'll then briefly review the therapies available for treating CLL and mantle cell lymphoma in the United States and EU to discuss some patient cases together from the viewpoint of our roles on the MDT. And finally, we'll look at some of the common adverse events associated with these therapies. So let's start by talking about multidisciplinary care in CLL and MCL and the role of the multidisciplinary team. So we have a multidisciplinary group here today to discuss the management of CLL and MCL. And let's take a few minutes to discuss some of the key players. We have hematologists or oncologists who direct and prescribe the therapy for the patients, advanced practice providers and nurses who help provide additional care for patients in the clinical setting. We have pharmacists who are available and help craft the treatment plans for chemotherapy, case managers and social workers who help make sure that the patients are able to get to their appointments and have all the resources necessary to do the treatments that we prescribe. We have pathologists who help us make the diagnosis and assist in the genomic and other risk stratification for patients throughout the duration of their treatment. We have radiologists who help with response evaluations, who perform biopsies to help make these diagnoses. In some cases, radiation oncologists who help deliver radiation. And occasionally, if transplants are needed, this would involve transplant physicians, if these are different than the primary hematologists or oncologists, as well as transplant coordinators. We also, in some cases, will have a palliative care team to help with symptoms. Sanam, I'm wondering if you could help us, with your role as a pathologist.
Sure. So, as a pathologist, I'm responsible for making the diagnosis. And as you mentioned, providing information on genetic and other risk stratifying factors that'll help guide therapy. So in a patient, let's say with CLL or a frontline mantle cell lymphoma, usually what my job entails is making a histologic diagnosis, so confirmation of the histology. And that involves assessment of the burden of disease. Let's say if a bone marrow biopsy is done, how much of the bone marrow is involved by disease. And then there's immunophenotyping. Typically, these lymphomas have characteristic immunophenotypes. Again, we use flow cytometry and immunohistochemistry to confirm the immunophenotype. And then there are several genetic studies, be it from a routine karyotype or FISH panels or fluorescence in situ hybridization panels that are done to look for recurrent karyotypic abnormalities, and then sequencing studies to look for mutations in the variable region of the IGH or somatic mutations that have prognostic or predictive relevance in the context of disease.
Great, thank you. And Josie, I know not all of the physicians that are watching have the opportunity to work with advanced practice providers. I wonder, you see patients by yourself, you see patients in collaboration with physicians on the team. I'm wondering if you could comment a little bit on your role.
Sure. So I work alongside our CLL physicians, and we see, as APPs, we see patients independently. I think the role of the APP differs across different institutes. But at our institute, I see patients independently, often alternating visits with our physician colleagues. And once a patient starts on treatment and needs more frequent visits, I'm often seeing them more frequently than the physician will. And so that gives me a really great opportunity to get to know the patient outside of their disease, which can be really helpful in guiding them on managing their side effects or any disease-related symptoms, as well as letting the physician know of any logistical barriers or psychosocial barriers that they may want to weigh in when they're recommending treatment options for the patient.
Thank you. That's very helpful. And then, Peter, I'm wondering, when you're seeing patients in your practice, what members of the multidisciplinary team are there in the room with you or kind of available in close collaboration versus ones that are maybe more removed?
Yeah, thank you, Jen. If it comes to CLL, it's, let's say, mostly the hematologist who is dealing with the patient because everything is more or less in his hands. So with the CLL, the MDT is not that a big issue. If we proceed with these patients to cellular therapies for more complex therapies, then other players come into the game. And these are mostly case managers who are making the appointments and doing, let's say, the easier things with the patient and explaining them what's going on with their treatment and helping me getting through with the patients.
Great, thank you. I'd also love to talk a little bit about strategies to ensure that the multidisciplinary team is effective and is efficient. I can say from my standpoint, I see primarily patients with CLL, and we keep our multidisciplinary team organized through regular meetings of our CLL group, which include most of the members that we've talked about. We also will have pretty constant streams of communication during clinic with the case managers and the social workers and nurses, nurse practitioners or physician assistants and pharmacists who sit with us in the clinic as well. Peter, anything that you do in your practice to ensure that the multidisciplinary team is working effectively together?
Yeah, of course, we also have regular meetings. We have weekly conferences, not only tumor boards, but also quality assurance meetings where we are discussing the patient's course during the treatment and after the treatment and any safety issues with the members. You mentioned already also the social assistants. They are not sitting in every meeting, but of course they are involved if it comes to get the patients along or achieve some let's say, help in their private home or issues like that, they get involved. But the main tool which we use is regular scheduled meetings.
That's great. So hopefully our takeaway from here will be that the multidisciplinary team has complementary expertise and that this expertise helps to ensure that patients are receiving comprehensive care. Let's move on to our next section, which is thinking a little bit more in detail about the management of CLL and mantle cell lymphoma. So let's start with CLL, and we'll talk about frontline therapy and then second line or subsequent therapy. So frontline options for CLL are continuous BTK inhibitor-based therapies, which can be alone, or in the case of acalabrutinib, can be with obinutuzumab, or BCL2 inhibitor, specifically venetoclax, containing fixed duration regimens. The fixed duration strategies that we primarily use in the frontline setting are venetoclax plus obinutuzumab, or venetoclax plus acalabrutinib with or without obinutuzumab. We actually, in many cases, choose between these paradigms based on patient preference. But we also think about comorbidities, concomitant medications, and other factors when choosing which of these paradigms we're going to use for our frontline treatment strategy. As far as second line therapy, we generally use whatever paradigm was not utilized in the frontline setting. So if somebody has covalent BTK inhibitor as their frontline treatment and is on that until disease progression, we would switch to a venetoclax-based regimen at that time. Someone who has been treated with venetoclax, either with obinutuzumab or acalabrutinib in the frontline setting, if they have a long remission duration, could use the same treatment again, or could then move to a covalent BTK inhibitor given continuously at that point. For patients who become refractory to both BTK inhibitors and venetoclax, the best data that we have and what's included as recommended in the NCCN guidelines are the non-covalent BTK inhibitor pirtobrutinib, as well as CAR T cells. Clinical trials are still exceptionally important for patients with CLL, especially these dual refractory patients, but really should be considered in any line of therapy. Peter, I wonder if you might have any comments on how the practice differs in Germany and the European Union.
Yes, thank you. In the first line treatment, all what is written at the very bottom of this column is, let's say, not recommended anymore as routine. This is all the chemoimmunotherapy. So these regimens are not really fashionable anymore. In the second line, we are restricted by the approval situation of some drugs. So there's no obinutuzumab in Europe approved. So we are thrown back to venetoclax rituximab in the second line if we have to go for BCL2 inhibitor containing regimen. And there's also no approval because this is the approval fixed to first line for venetoclax and ibrutinib or acalabrutinib, which has become approved just very recently. There is unfortunately no approved products for CAR T-cell therapy in Europe. And the next slide, where the European or the ESMO and German guidelines are summarized, I can comment that although idelalisib is in first-line therapy approved and possible, nobody is using it. We have now pirtobrutinib available in Europe, and the label is a little bit more permissive than it is in the US because there is no restriction to two prior regimens, so it's not restricted to the third line plus. So, but you can use it in every patient who has failed or who has been treated with a prior covalent BTKI. So if a patient has become in the first line refractory to ibrutinib or something else, you can immediately switch to pirtobrutinib if you deem this is reasonable. I think these are the major differences between the two sides of the Atlantic.
Thank you. That's very helpful. So let's move on to mantle cell lymphoma. So for frontline mantle cell lymphoma management, we think about induction therapy and then maintenance therapy. And we break down induction therapy by stage and TP53 status, as well as suitability for aggressive induction therapy. In the past, it was often assumed that people who got aggressive induction therapy would go on then to an autologous stem cell transplant. This is now still considered for some individuals, but is not a blanket recommendation across the board. For maintenance post-transplant or post-aggressive induction therapy, we think about covalent BTK inhibitor plus rituximab, where the covalent BTK inhibitor is given for 2 years and the rituximab given for 3 years. Maintenance rituximab can be considered after bendamustine rituximab or bendamustine-based regimens or R-CHOP as well. And again, clinical trials are, of course, appropriate in this setting. Peter, any alternatives or other things that you tend to use more often in Europe?
Yeah, thank you. Of course, let's say the algorithm is a little bit different in Europe, and this has also to do with the approval status once again. So zanubrutinib and acalabrutinib are not approved for mantle cell lymphoma. So some of these combinations are not available for us.
Thank you. Peter, I wonder if you might take us now through the relapsed refractory mantle cell therapies.
What are we doing for the relapse patient if they have received ibrutinib or BTKI in the first line and they are relapsing or progressing? during the induction or the maintenance with ibrutinib, then they are not formally, we have not formally an approval, but at least in Germany, they will be reimbursed if they then are going on the CAR T-cell regimen. If the patient has to be bridged or is not considered eligible for CAR T-cell therapy, which will be the minority, then pirtobrutinib is an option for bridging or for stabilization or for, let's say, definite treatment of these patients. The venetoclax option, which might be available in the US, is not approved in Germany. So it's not the first choice, only in specific cases in Germany or Europe. And those patients who have not seen BTKI, they are going on ibrutinib as the only approved BTKI currently for mantle cell in Europe. This is the early relapse. The late relapse, meaning beyond what we consider POD 25. So they will may come back to ibrutinib if there was a larger interval between ibrutinib completion during the first-line treatment and the relapse. Then we have the option, of course, of pirtobrutinib. Again, this is approved in Europe as second-line therapy if a covalent BTKI has been given before. And I think if it comes then to the next line, and we have two lines, and of course one of them is always then a BTKI, then we are in the heart of the label of the CAR T-cell treatment. And if CAR T-cells are failing, then we are in another step where we may consider stem cell transplantation, allogeneic stem cell transplantation, although only few patients will reach the situation where this makes sense anymore. I think I stop here and give the ball back to Jen to summarize and tell us about the US situation in the relapse setting.
Sounds good. Thank you. So I agree with, I think in the United States, our guidelines focus a little bit more on what was given as the first line therapy. So whether they had been exposed to a continuous covalent BTK inhibitor or a fixed duration strategy, the availability of a couple additional covalent BTK inhibitors, acalabrutinib and zanubrutinib, availability of venetoclax with or without rituximab, or venetoclax given with ibrutinib. And then one additional therapy after CAR T-cell and pirtobrutinib, or for those patients who are ineligible for CAR T and who had pirtobrutinib, would be the bispecific antibody glofitamab. So, Sanam, I'm wondering your thoughts. With so many of these treatment options available, we need guidance on how to select the best treatment for our patient. How can the pathologist help us with this?
Sure. So I think the main role we have is really determining the genetic factors that determine response to therapy. For CLL, as I mentioned before, I think the IGHV status is important. So, deviation from the germline sequence is how we determine whether we have an unmutated versus a mutated CLL. Patients with mutated CLL respond better to chemoimmunotherapy type regimens, whereas unmutated patients don't respond as well. So you need alternative targeted therapies for them, like BTK inhibitors. And then somatic mutations, most importantly being TP53 mutations, are very important both in the setting of mantle cell lymphoma and CLL. So it really all relies on the genomics in the front line. And then, of course, in the relapse refractory or after therapy, particularly with BTK inhibitors, we're concerned with and assess for mutations that would confer resistance to BTK inhibitors, the most important being the hotspot C481 residue in the BTK, and then other alternative mutations that can either bypass the BTK pathway or are downstream of BTK itself that would confer resistance. So really, sampling is important for determining genomics, and I think we're going to talk about Richter's separately, but that's also another important issue that we assess in patients that are suspected to have transformed disease.
Great, thank you very much. And then Josie, as a nurse practitioner, how do you help ensure that a more holistic approach is taken for patient care? So not thinking just about the genetics, but about the patient themselves.
Yeah, so I think this is a really important topic because, as you pointed out, especially in the CLL field, so much of our treatment decision making now is based on patient preference and not necessarily disease related factors. So, as the advanced practice provider and our oncology nurse navigators, we can play a role in speaking with the patient, getting to know who they are, what pre-existing health conditions they have, what their medications are that they're already taking, make sure that none of the treatments we're going to be recommending interact with their meds or may exacerbate pre-existing health conditions, as well as, again, sort of assess for any other barriers to treatment, logistical being what's their accessibility to clinic. Are they an elderly patient that requires friends and family to drive them long distances to their appointments, in which case a treatment with frequent visits may not be appropriate for them? Or are they a patient that has significant financial concerns about a oral therapy, in which case a continuous oral therapy indefinitely may be more financially toxic to them? So, assessing who they are outside of their disease can be really impactful in weighing in the treatment decision-making process.
Thank you. So as you can see, we utilize our multidisciplinary team to incorporate both clinical features and genomic features to determine the optimal therapy for an individual patient. So now let's move on to some cases. Our first case is going to be a CLL patient named David. David is 67 years old, has a history of hypertension, coronary artery disease, for which he is currently on dual antiplatelet therapy, and a history of multiple basal cell skin cancers. His initial presentation involved with bothersome lymphadenopathy in his neck, which had been occurring for about 4 months. He notes that the lymph nodes aren't painful, but they're getting uncomfortable as they're growing. He has moderate fatigue and no other symptoms. CBC shows a white blood cell count of 32 with a lymphocyte count of 28. Hemoglobin is slightly low at 12.2 and platelets slightly low at 130. He has flow cytometry performed, which is consistent with CLL, and has genetic studies performed which show IGHV unmutated disease. Cytogenetics and FISH are performed, which show trisomy 12, and next generation sequencing shows no abnormality in TP53. So Sinan, first question for you. Is there any need for a lymph node biopsy to confirm diagnosis in somebody with CLL?
I would say yes, but of course I'm a pathologist. But yes, because there are, alternative causes for lymphadenopathy. And of course, you want to make sure that this is actually the CLL. So I would say, while you don't absolutely need, in a patient that presents with lymphocytosis, obviously, you can sequence the blood, perform the immunophenotyping on the blood. But I would say that best practice is probably to do a lymph node biopsy to make sure that what's involving, what's causing the lymphadenopathy is actually the CLL as well.
And let's talk a little bit about flow cytometry. So I'm wondering if you can help us walk through kind of how to differentiate between CLL, mantle cell lymphoma, marginal zone, other things that we might see in the peripheral blood.
Sure. So when we think about CLL, the immunophenotype in particular, we have a immunophenotype that we consider classic for CLL, and that is really dim expression of B cell markers such as CD20, CD22, CD79A, and the light chains. And then, presence of CD23, of course, presence of CD43, ROR1, and CD5. So this would be a classic CLL phenotype where if I get a peripheral blood like this, I'm very comfortable making a diagnosis of CLL just on the peripheral blood, even really without seeing the morphologic features. This is pretty typical. And then you have certain genetic abnormalities that may present, that are still CLL, but those CLLs may present with an atypical immunophenotype, the most notorious being CLL with trisomy 12. So an atypical phenotype is when you have either bright expression of the B cell antigens or the kappa lambda light chains, or you have absence of CD43, absence of CD23. Again, not much prognostic, but then they do pose a challenge when trying to distinguish CLL from mantle cell lymphoma, which can have, again, CD5 co-expression, but have bright CD20, bright B cell markers and IG and immunoglobulin light chain expression. What I find is the most helpful in distinguishing the two is CD200 and ROR1. So CD200, whenever you see uniform bright expression of CD200, this is usually going to be a CLL. Even in a typical CLL, the bright uniform expression of CD200 is preserved, and that's what we really use. But then there's always the caveat of having the non-nodal leukemic mantle cell lymphoma, which can also have CD200 expression. So really the gold standard is, if you're in any doubt, you should send for FISH and look for cyclin D1 rearrangement.
That's great. Thank you. So in cases where you have flow cytometry that is very consistent with CLL, no need for additional biopsies or anything like that. If there's anything that makes it more atypical, or if there's any concern about this being a different hematologic disorder, like especially mantle cell marginal zone, lymph node biopsies, bone marrow biopsies can be extremely helpful.
Definitely.
Okay, and then Josie, can you comment on specific things that you're looking for in history or exam that might help you make your treatment decisions?
Sure. So I think a big part is looking at what the patient's past medical history and current medication list reveals. So for this patient specifically, what stands out the most to me is his history of coronary artery disease and his dual antiplatelet therapy. One of our big drug classes that we use commonly to treat CLL is our BTK inhibitors. And those do come with the risk of additional bleeding, easy bleeding, and bruising. So generally, we do try to avoid that type of medication when someone's on dual antiplatelet therapy. If he was only on one type of anticoagulation, such as a DOAC, then that could be used concurrently with a BTK inhibitor. But the dual antiplatelet therapy would make me worried about extra bleeding in this patient. So I think that I would have a discussion with him about whether he may be able to and willing to do a venetoclax-based regimen and assess for any logistical barriers in him completing the frequent visits that type of treatment requires. And if he's able to, I think I would tend to recommend that over the BTK inhibitor because of his bleeding risk.
Great, thank you. So after discussion of the risk benefits of different therapies, the patient was initiated on venetoclax plus obinutuzumab. For the reason that you mentioned, Josie, the dual antiplatelet therapy makes the bleeding risk fairly high with BTK inhibitors. Peter, any additional comments on this? Would you choose anything different for this patient?
I think the most is already said. I think also our choice or recommendation in this case would be venetoclax obinutuzumab because of the bleeding problems associated with the antiplatelet therapy. And on the other side, this patient, at least in this first line treatment, does not has really genetic problems or high risk genetic profile, which would let us doubt that venetoclax can provide a prolonged disease control. So I think this is a clear recommendation, as you did already for venetoclax obinutuzumab.
I agree. And Peter, do you want to take us through our next case?
Yeah, thank you. So this is an old lady, 70 years old, and she has some diseases which might be very common in that age. So she has a hypertenus and a diabetes, but is in a very good shape. And she came to us with the diagnosis of a classical mantle cell in stage 4B with some night sweats that define the B, and bone marrow involvement 40%. And that she also had the general lymphadenopathy, some splenomegaly. So the mantle cell lymphoma was everywhere, but not outside of the lymphatic system. There was no bowel involvement or something like that. There was a high MIPI, and at that stage, the TP53 status was not evaluated. So she was, because she was an old lady, started then on rituximab and bendamustine without ibrutinib, and she had a complete response and did quite well. So she was started on rituximab maintenance, and that went without complications for 2 years. So January 2023, rituximab maintenance was stopped, but soon the relapse was observed in the summer of that year. Formally, that was no POD 24, but of course, it was a quite early relapse. And I think at that stage, no biopsy was taken. So she was started on ibrutinib right away as a, let's say, common second-line treatment. And maybe I can make a break here and ask Sanam if she would have seen that differently, meaning that a biopsy would be appropriate at this stage.
Sure. So I think, I would kind of bounce that back to you and say, if the cytology is important, so if a blastoid variant or a pleomorphic variant of mantle cell lymphoma will alter the course of therapy, the burden of disease, of course, and then, a couple of prognostic markers that we can do, like Ki-67, so the proliferation index of the mantle cell lymphoma will alter how you're going to treat this patient, then yes, biopsy would be very helpful. And those are, that's information that we can provide only through tissue biopsy.
Yeah, thank you. Jennifer, if you would like to comment on American treatment options for the first line and maybe also in the relapse setting now.
Yeah, I mean, I think that probably in the US, we would have done the exact same thing as you in the frontline setting for somebody who is not likely to tolerate aggressive therapy, bendamustine, rituximab with rituximab maintenance. Certainly, ibrutinib is a good option for second line treatment. And in the US, we might also have considered one of the second generation BTK inhibitors just with a little bit more favorable safety profile.
Yeah, thank you. And Josie, would you like to comment on disease characteristic or patient characteristics which might affect the choice of the next line of treatment?
Yeah, so, we always start with looking at the patient's fitness status as well as their pre-existing health conditions. In an elderly woman like this, as with a lot of our patients that we treat with BTK inhibitors, the first thing that always stands out to me is potential aches and pains that they already have, either muscle aches or arthritic aches that may be already debilitating to them or impacting their functional status. We know that sometimes BTK inhibitors can exacerbate these. So that would be something that I would counsel this patient on and really focus on strategies to help with that if it should occur. Otherwise, as I would with anyone starting on a BTK inhibitor, I would counsel her on the easy bleeding and bruising side effect associated with the BTK inhibitors, especially to let her know that if she has any falls at home, she needs to be evaluated very quickly because she's more likely to have internal bleeding on these types of medications. And then also counsel her on the cardiovascular risk, the risk of atrial fibrillation and worsening hypertension. And then lastly, sometimes early on in treatment, we can see some GI disturbances like diarrhea that usually self-resolve, but would be important to let this woman know so that if it does occur, she doesn't just stop treatment because she's having side effects, and she can work with us on how best to manage those GI effects.
Yeah, thank you very much. So let's go on with the course of this patient. So the ibrutinib didn't work very well. In the end, there was no response at all. And in December 2023, so 5 months after starting ibrutinib, the decision was made to do a biopsy, and this revealed a quite high proliferation index, key 67 or 50%, and that was also in these cells. 30% had a p53 expression. So Sanam, can we call that high-risk mantle cell lymphoma or and blastoid variant, or do you need any more to do this diagnosis?
I mean, I think with the high proliferation, it's certainly a concern, but the strict definition of blastoid is still a histologic, definition. So you want to have the histologic features of blastoid morphology, and of course the increased proliferation and increased mitotic activity, which is of course also the proliferation rate.
Yeah, thank you. This was very clear. So in this, in let's call it desperation, or to give the patient immediate release, because you can see from the CT scan that there was some pressure on the neck already. So she was treated with R-CHOP. She had seen chemoimmunotherapy in the first line, bendamustine. So now with a more aggressive character, although which was not formally called blastoid variant, this patient was given 2 cycles of R-CHOP, but she didn't respond. And then because it was only a local progression, the radiotherapy was given to this patient. Again, there was no clear regression of the tumor masses. You can see the CT scan here. And Jennifer, it's up to you to comment on that. What would be your strategy in this setting, in this, let's say, BTKI or ibrutinib refractoriness, how to go on here?
Yeah, so I think, options at this point, obviously, she's had a covalent BTK inhibitor. You could consider pirtobrutinib. CAR-T would be an option as well. I think since both are available, maybe using the pirtobrutinib first to get a quicker response, and then proceeding with CAR-T at some point later.
Yeah, so exactly. At that time, the patient was referred to evaluator for CAR-T cell treatment. And because we didn't like this bulky tumor on the neck so much, we started her on pirtobrutinib. At that time, it was not approved, but we had a compassionate use program running. So she started on pirtobrutinib, and had a quite good clinical response. You could see this tumor shrink. And when we did a PET scan, let's say 2 months only after starting pirtobrutinib, we saw that there was already a metabolic remission. As you can see here from the PET scan, that there was no metabolic activity visible again. And we used that for bridging her into the CAR-T cell program. That's by the way. This might be another question for Jersey. Considering now that pirtobrutinib treatment with the perspective of proceeding to CAR-T cells, what adverse events would you be advising the patient about when we are considering this treatment sequence.
Yeah, so with counseling her on pirtobrutinib, fortunately, it sounds like she tolerated ibrutinib okay. So, I would reiterate that pirtobrutinib is within the same drug class, so we generally would expect the similar side effect profile. So I'd re-educate her on what that looks like, the risk of the easy bleeding and bruising, GI disturbances, cardiovascular effects, and arthritic and pains and myalgias. I would let her know, though, that fortunately pirtobrutinib is a little bit more of a selective BTK inhibitor, so often we don't see quite as frequent or significant side effects on pirtobrutinib than we do on ibrutinib. So I would hope that she would tolerate that treatment very well in preparation for CAR T cells.
Yeah, thank you. Excellent. Then finally, she proceeded to Brexucel. That was in September. Again, we had a metabolic complete remission, and she did quite well. Unfortunately, then she was infected with the COVID virus, so she passed away, being at home without any, let's say, dramatic symptoms before. So in the end, it was a very tragic course, but the treatment was working very well. But this highlights another problem, which is associated with these, let's say, all B cell targeting approaches we have been discussing tonight, that there is, and in particular associated with the CAR T cells, which also may affect the T cell function and the neutrophil numbers, that there is a considerable risk of infection. So CAR T cells are not a very trivial treatment, and they have to do, let's say, under a strategy of close surveillance to avoid, in particular, infections. Maybe, Josie, is there a specific counseling, specific advice you give the patients who are undergoing CAR T cells?
Yeah, so in our practice, we first assess whether they're able to logistically do the CAR T cells. So because of some of the side effects associated with CAR T cells, such as the cytokine release syndrome and the neurotoxicity, we do recommend that all patients proceeding with CAR T cells get their CAR T cells in the hospital and then stay close to the hospital with a caregiver for at least a few weeks after that treatment so that we can closely monitor them. So the first thing is to make sure that they can do that and they do have a caregiver available. And then after that, and we do proceed with the CAR T cells, we would be counseling them on the risks of cytokine release syndrome, which often would occur in the hospital. So less likely to occur once they were discharged, but still something we'd want them to monitor for and make sure they have a thermometer and blood pressure cuff at home. Additionally, the signs of possible neurotoxicity, which sometimes can present once they are discharged from the hospital, and to make sure that both the patient and especially the caregiver is aware of what to look out for, as often it's the caregiver who notices subtle neurologic changes before the patient or even us. And then we'd want to make sure we're counseling them on the risks of cytopenias and infection post-CAR T, so that patients are being mindful of infection exposure and counseling their friends and family to let them know if they're sick, they shouldn't be coming over and visiting the patient.
Yeah, thank you very much. Perfect. Jennifer, a few words for the scenario that this lady might have failed CAR T cells. So if she had an early progression or relapse, what would be your ideas how to proceed?
Yeah, so one option would be using, again, the bispecific antibody glofitamab, which has been specifically investigated in this setting. Some of the side effects are similar to CAR T, of course, as Josie had mentioned, but it does have a high complete response rate in this setting. Okay, so let's move along to our last case, and this is going to be another CLL case. A patient named Carol, who's 58 years old. She has a history of CLL, actually required her first treatment at the time of diagnosis when she received venetoclax plus obinutuzumab given for 1 year. She unfortunately had progression of disease about 6 months after finishing that therapy and was started at that time on acalabrutinib. She continued the acalabrutinib for about 6.5 years. However, 4 months ago was noted to have an asymptomatic rise in her absolute lymphocyte count with no other symptoms. Currently, her ALC has risen to 20, and she's starting to develop new lymph nodes. She's started to develop night sweats, which happen about once a week, and has lost 5 pounds over the past month unintentionally. On laboratory studies, her white count is 22, hemoglobin and platelet counts are normal. Her LDH is 400, where the upper limit of normal here is 190. She had not previously had genomic studies performed, so they're performed at this time. IGHV is found to be unmutated. The karyotype is highly complex, which is defined as 5 or more abnormalities. She has 17p deletion and 11q deletion on FISH. NGS shows a BTK-C41S mutation, a TP53 mutation, and a NOTCH1 mutation. So I think, one of the things that we worry about in scenarios like this with new lymph nodes, night sweats, weight loss, especially in the setting of a high LDH, would be the potential for Richter's transformation. So I wonder, Sanam, if you might comment on how to work up suspected Richter's transformation and then how to differentiate it on biopsy from a flare from holding a BTK inhibitor.
Sure. So I'm going to say that in this scenario, I must insist upon a biopsy. So the gold standard here would actually be to do a tissue biopsy. I think this patient, both the clinical scenario and knowing the genetics of her disease and how high risk of a disease profile she has is highly suspicious for having Richter transformation. And really, to make that diagnosis, we need histologic confirmation of transformation. Now here, again, there are several scenarios that may fit into the differential diagnosis, including a flare, which is a transient phenomenon that happens after BTK therapy. I think she's, you said how far out of therapy is she? How long ago did she start getting BTKs?
She'd been on it for 6.5 years, but has had progression for almost 6 months at this point.
Yeah, so I think, the timing is not exactly great for a flare. It's more suspicious for having transformation. But again, for a flare, you would expect, first of all, for it to be transient. The LDH shouldn't be that high. The morphology should not be transformed. So morphologically, we don't want to see any evidence of large cell transformation. So I would highly recommend that this patient get a lymph node biopsy, and preferably of the excisional type if that's possible. I know at most of our centers, really nobody's doing excisional biopsies anymore, but that would really be the gold standard. But we'll do with a needle biopsy if that's what you're going to give us.
Thank you. And just to clarify the question a little bit, so many times, especially if we're going to do an excisional biopsy, we'll hold the BTK inhibitor for the biopsy. And in these patients who are progressing like this, a lot of times that can cause some flare of the disease. How do you, when you're looking at the biopsy, take that into account when you're trying to differentiate Richter's from a flare?
Right. So for, you mean the timing or the features?
So I mean, in the patients who hold their BTK inhibitor for the biopsy specifically and have a flare of the disease while holding the BTK inhibitor for the biopsy.
So again, histologically, we don't expect to see morphologic transformation in a flare. You may see, a rise in their lymphocyte count. You may see a bit more, proliferative disease, but we don't expect to see sheets of large cells. Whereas for Richter transformation, really you would see histologically transformed disease that looks like diffuse large B-cell lymphoma.
Okay, thank you. So in this case, the biopsy did not show evidence of Richter's transformation and showed aggressive CLL. So in this patient who has dual refractory disease, so they have had disease progression a short time after venetoclax and on a BTK inhibitor, we'd consider treatment options including pirtobrutinib or liso-cel in addition to clinical trials. Josie, I wonder if you might comment on some characteristics that might make you choose one or the other for those two treatment options.
Sure. So I think the thing that stands out to me the most is that the patient's becoming more and more symptomatic from their disease and does have those high risk aggressive features, which makes me think that whatever treatment we give the patient needs to be started fairly imminently. CAR T cells could be a promising option for this patient, but after the cell collection, it could be a few weeks before the cells are manufactured and then infused back into the patient. So, in that time, the patient's disease may explode and really progress. So, I think she needs something sort of off the shelf, immediate for the time being. And then maybe she could have CAR T cells down the road. So, given she has the C481S mutation, I think pirtobrutinib would be a great immediate fix, but probably won't last forever. And this patient is still quite young. So, could be that bridging therapy to the CAR T cells or a more durable treatment option.
Thanks. And Peter, I wonder if you might comment just with, different drugs being available in the EU, what would you choose for this patient?
The problem is that CAR T cells, as I already mentioned, are not approved in Europe for CLL. So we could put her on a trial, or yes, or in this really worst case scenario, and this young patient who probably will not get old with this genetic profile and all the failures we have already seen in her history, we would here consider allogeneic stem cell transplantation.
Great, thank you. So this patient did go on to receive pirtobrutinib, responded very well to it with the plan to receive liso-cel in the future. And, this could wait until relapse, but potentially would not necessarily wait until the patient had a florid relapse before moving to CAR T. So thank you so much, everybody, for the discussion on those cases. Now we'd like to spend just a few minutes talking about managing some of the specific adverse events that we've, for the therapies that we've discussed. Josie, can you take us through a few things?
Sure. So when I'm thinking about managing any potential side effects for my patients on these treatments that we've discussed, I always go back to what are the considerations for their frontline or relapse refractory treatment, and how may that impact what side effects they experience while on treatment. I think we have a variety of different treatment considerations that the multidisciplinary team considers when they're recommending treatment. I think we've done a great job already reviewing how all those factors play a role in our cases. But again, really highlighting the pre-existing comorbidities and the medication reconciliation that needs to be done prior to treatment in order to optimize the patient's benefit of the treatment. So highlighting one of our most commonly used CLL treatment options, the venetoclax and obinutuzumab regimen, I think the first thing that comes to anyone's mind is the risk of tumor lysis syndrome due to the rapid breakdown of CLL cells that then can contribute to electrolyte derangements. And I throw the schema of this trial in here because I want to highlight how important the debulking obinutuzumab is prior to a patient receiving venetoclax in reducing their risk for tumor lysis. So for any of these patients starting on venetoclax, they should have a full tumor lysis risk assessment, including CT scans and an absolute lymphocyte count to determine their TLS risk. But the obinutuzumab preceding the start of the venetoclax 5-week escalation does do a great job at debulking and further minimizing the risk of tumor lysis. And in addition to reducing someone's tumor lysis risk, any patient, regardless of risk stratification, should be started on an anti-hyperuricemic agent, usually an oral agent that they'll take through the duration of their venetoclax escalation. If someone did have signs of tumor lysis, laboratory or clinical tumor lysis during their escalation, we would manage that by treating the specific electrolyte abnormalities that we were seeing. Other risks that we always counsel our patients on while they're on a venetoclax-based treatment is the risk for infections and neutropenia. Neutropenia is very common throughout the venetoclax therapy course, and often, fortunately, is very treatable with growth factor support. So we usually don't need to hold the venetoclax dosing. We can provide growth factor and treat through. But if someone was having repetitive episodes of neutropenia or certainly febrile neutropenia, you could always consider a dose reduction in those cases. And then lastly, I think one of the more common side effects that my patients report to me is the gastrointestinal upset that sometimes they can experience after they take venetoclax. So this may include some diarrhea or nausea or bloating. And usually this is because the patients are not taking venetoclax with food. So it's really important to advise your patients to take venetoclax with a meal, ideally a fatty component to the meal. And if they're dosing in the morning and they're still having some of these GI side effects, they could switch to nighttime dosing to hopefully sleep through any of the GI disturbances. Here's an overview of some of the class side effects that we see with BTK inhibitors. I think we've discussed a lot about these effects in the cases, but again, just to review that commonly on BTK inhibitors, we're seeing these nagging side effects. They're not the life-threatening side effects, but they are nagging and they bother patients sort of day in and day out. So it's really important to counsel your patients on these right from the get-go, because often they occur right from the get-go and do tend to get better over time. But if your patients are not prepared for that, they may have more difficulty tolerating the treatments and be more apt to not adhere to the treatment or stop without telling you. And then, of course, we want to be mindful of the more life-threatening cardiovascular side effects that sometimes we can see, especially with the atrial fibrillation or other cardiac arrhythmias. If your patient has a pre-existing cardiac condition, it would be prudent to consider baseline cardiac testing with an echo or EKG, just so that, down the line, if they do start reporting new cardiac symptoms, you have a baseline comparison. And then when we get to the relapse refractory setting in CLL, as I mentioned, even with the frontline setting, still important to reassess where your patient's at. Has their comorbidities changed? Has their logistical barriers or psychosocial barriers changed? You're constantly reevaluating this to maximize their benefit from any future treatment, as well as minimizing any potential adverse effects they may feel. And with regards to side effect management for mantle cell lymphoma, a lot of mantle cell lymphoma is doing some combination of targeted therapy plus or minus chemoimmunotherapy. So when we're thinking about managing chemoimmunotherapy, it's pretty standard managing the cytopenias, infection, antiemetic support for any nausea, and monitoring for worsening peripheral neuropathy. Specifically with some of our cardiotoxic chemos, you'd want to do baseline cardiac testing in case they were to start having signs of worsening cardiac function. And then we do see a fair amount of lenalidomide used in mantle cell lymphomas. So that comes with the unique side effect of thrombus. So you would want to start someone on like a baby aspirin in that case to help manage that. We already sort of talked about some of the covalent BTK inhibitors and pirtobrutinib that we're using in mantle cell lymphoma and how to manage those class effects, as well as venetoclax and the risk of tumor lysis. Lastly, I will just mention CAR T cells again, since it is such a large endeavor often for the patients. As I mentioned in the case, often at our institute, we're requiring patients to get their CAR T cells in the hospital and then need to stay close by with a caregiver support shortly after that. So assessing those barriers and managing those logistics requires a team in and of itself. Fortunately, we have an excellent CAR T team that can help assist with that. And then educating the family and the patient on the side effects of the neurotoxicity and cytokine release syndrome and infection, really to promote their health after they get discharged from the hospital. And here's just a little schematic on sort of how the CAR T process works. Again, keeping in mind your patients that have really aggressive disease, you're going to want to have some sort of bridging therapy available to them so that they do get some symptom and disease support during that manufacturing window of the CAR T cells. And here's a nice little overview on specifics on how to manage cytokine release syndrome and neurotoxicity.
Thank you, Josie. That's really helpful. You kind of touched on this as you went, but would you mind weighing in a little bit on the roles of specific members of the multidisciplinary team when managing these AEs?
Yeah, so, I think everyone has their role as an advanced practice provider. I'm often the one sort of in the front line, seeing the patients as frequently or infrequently as they need, doing a lot of the telephone triage and doing a lot of the medication ordering and diagnostic ordering, working in counterpart with my physician who would do all the reviewing of the test results and overall dictating the care of the patient. And then, of course, we have our ever important oncology nurse navigators and pharmacists who do a lot of our drug education and treatment education for the patients before and after they've received treatment to make sure that everything's going smoothly. And I think, as Peter pointed out, with some of these therapies, we then will consult other specialists to weigh in, such as cardio-oncology and dermatology and anyone else that may be able to help in the care of the patient.
Thank you, Josie. That was very, very helpful. So I think for our listeners, our takeaway here is that when we have a lot of therapies to choose from, like we do now in CLL and mantle cell lymphoma, thinking about some of these as potential adverse events can help guide our decision-making process. And as well, when patients are on a therapy, proactively managing toxicities is important to help with therapy compliance and ensure the best outcomes we can give to our patients. So I'm going to ask my fellow panelists, what are your final thoughts for our learners on working with the multidisciplinary team to manage CLL and mantle cell lymphoma to optimize patient outcomes? I think from my perspective, it's that it really does take a team to care for these patients. If you don't currently have a multidisciplinary team that is helping you take care of your CLL mantle cell lymphoma patients, now is a good opportunity to start building that team. Sanam, what would you like to say for your final thoughts?
I would reiterate exactly what you said and emphasize the importance of working together and having a multidisciplinary team. And of course, active communication while we're trying to determine what's best for the patients. Thank
you. Josie?
Yeah, I will echo what you both said and add that, in the advent of all these more personalized treatment regimens to our patient, that's where the multidisciplinary team really shines in evaluating the patient from every perspective to lead them down the best course.
Thanks. And Peter, I'll give you the final word.
I might add that not every patient or not in every disease setting, the MTD is as important as it is in more advanced disease settings with more complicated and complex treatments involving much more disciplines. But I stop here.
All right. Thank you. Thank you so much, Josie, Peter, and Sanam for this great discussion. And thank you all for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.